Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO!
This episode is dedicated to discussing immunotherapy in gynecologic cancer. Today, we're going to be discussing different types of immunotherapy, approved indications for use, and management of toxicities. Sydney, what are our learning objectives for today?
Our learning objectives are to review the biologic rationale for immunotherapy in the treatment of cancer, to discuss specific agents used and mechanisms of action, to discuss toxicities associated with use of immunotherapy in cancer, including resources for management by disease site, to review FDA approvals for immunotherapy in the treatment of gynecologic cancers, and to discuss non-FDA approved recommendations for the use of immunotherapy in gyn cancers.
So we wanted to first go over the basics of immunotherapy and why it works in the treatment of cancer. We're mostly going to be talking about immune checkpoint inhibitor therapy throughout this episode, and at the end, we'll mention a couple other types of immunotherapy. As we've discussed previously, tumors are able to exhibit unregulated growth by evading the normal checks and balances within the cell itself, as well as by evading the checks and balances in the immune system. Solid tumors, like gynecologic tumors, release tumor-associated antigens that get processed by antigen-presenting cells like macrophages and dendritic cells. These antigen-presenting cells present the antigens to CD4 T cells in the lymph nodes, and activated T cells then get deployed through systemic circulation, where they're able to target tumors by recognizing tumor-associated antigens to which they've been primed. Tumors thrive in an immunologically quiet state, and they need a way to avoid this recognition and destruction carried out by T cells. T cells and other immune cells use checkpoints to avoid destroying normal or healthy cells, and cancers have adapted to use this to their advantage. One of these checkpoints is expression of PD-1, a ligand which is responsible for preventing the immune system from attacking the body's own tissues. When bound to PD-L1, the attack signal is turned off on the T cell. This is the checkpoint. Many normal and healthy cells express PD-L1, which helps them avoid destruction by T cells. Tumors have co-opted this mechanism, have upregulated their expression of PD-L1 to essentially trick the T cells into treating these tumors like normal or healthy tissues and not destroying them. By utilizing this pre-existing checkpoint in the body, tumors evade the immune system. Another mechanism of immune regulation is CTLA-4. This is a receptor which is expressed in activated T lymphocytes and acts as an off signal or down regulator of T cell function. CTLA-4 competes for the same binding ligand as CD28, which is a T cell activator. CTLA-4 has a greater affinity for the binding ligand, and thus when it's expressed, it exerts a deactivating effect. Cancers have learned to directly express CTLA-4 as well as to induce expression of regulatory T cells, which heavily express CTLA-4, to avoid destruction by activated T cells. So Sydney, we just learned that tumors use PD-L1 and CTLA-4 to avoid destruction by the immune system. How have we, as cancer researchers and doctors, been able to use this in the treatment of cancer?
Great question. This brings us to our introduction to immune checkpoint inhibitors, ICI. The purpose of these, broadly, is to prevent cancer cells from hiding from the immune system like we just discussed. The types of immune checkpoint inhibitors currently used in GYN cancers are anti-PD-1, think receptor blockade, remember that the PD-1 is expressed on T cells, anti-PD-L1, think ligand blockade, expressed on tumor cells and other cells in the body, and anti-CTLA-4. Currently, anti-CTLA-4 agents don't have FDA approval specifically for gynecologic cancers, but have been investigated in trials with promising results. Is there a good way to tell whether immune checkpoint inhibitors will work?
There are biomarkers which can be predictive of response to immunotherapy, and these can be helpful in choosing which patients should get immunotherapy. In addition to disease site-specific indications, which we'll discuss later, there are biomarker-specific FDA-approved indications for immunotherapy, based on study results that demonstrate improved responses in tumors with specific biomarker makeups. Microsatellite instability and mismatch repair deficiency are markers which have been used in some studies and are part of the FDA approvals for many immune checkpoint inhibitors. MSI-high or dMMR tumors have high rates of mutations and neoantigen formation. Thus, they are more immunogenic than MSI-stable or pMMR tumors. MSI is obtained via sequencing, and MMR is measured on IHC. Finally, tumor mutational burden is another biomarker used to identify which tumors may benefit from the use of immunotherapy. Tumor mutational burden is obtained on sequencing, and there's an FDA-approved companion diagnostic from Foundation One CDX that can be utilized. Tumor mutational burden is measured in mutations per megabase, and generally a score greater than or equal to 10 is considered high TMB. PD-L1 expression can be one way to predict favorable response, and it's a criteria for some FDA approvals of immunotherapy. However, in gynecologic cancers, PD-L1 testing hasn't been as successful in predicting response as MSI, MMR, and TMB. That's why most of the FDA approvals for IO in gynecologic cancers aren't based on PD-L1, but we'll discuss that more later. PD-L1 expression is measured via IHC. The amount of PD-L1 expression is reported as a combined positivity score. This score measures PD-L1 expression on both tumor cells and immune cells, including lymphocytes and macrophages, and compares this to the number of total viable tumor cells. A PD-L1 CPS score greater than or equal to 1 is the cutoff used in cervical cancer. Some studies and some disease sites use the tumor proportion score, or TPS, which measures the proportion of PD-L1 positive tumor cells relative to the total number of tumor cells, but this is less used in GYN cancers. So I mentioned that these biomarkers were used to build some FDA approvals for immunotherapy. Sydney, can you walk us through the FDA approval for immunotherapy in gynecologic cancers?
Definitely. As you mentioned, there are several FDA approvals for the use of immunotherapies in GYN cancers. Let's talk about anti-PD-1 agents and their approvals first. Pembrolizumab is a humanized monoclonal antibody to PD-1. It has the widest FDA approvals and is the only one of these agents that has a tumor-agnostic FDA approval, meaning use of pembrolizumab is not dictated by a disease site, but rather by tumor characteristics. Pembrolizumab is FDA approved in the setting of MSI-high or MMR deficiency and for TMB-high tumors. For both of these, approvals are specific to advanced disease. The FDA approval for Pembro for MSI-high or MMR deficient disease is based on the results of Keynote 158. The approval is for patients with disease progression following prior systemic therapy in any setting and who aren't candidates for curative surgery or radiation. The TMB-high approval is also from retrospective results from Keynote 158 for unresectable or metastatic disease, regardless of disease site. Pembrolizumab also has disease site-specific FDA approvals. In endometrial cancer, Pembro is approved in combination with carbotaxol for the treatment of primary advanced or recurrent endometrial cancer, based on the results of NRG-GY018, also known as Keynote 868, regardless of MMR status, i.e., it's approved for all comers, for up to 2 years based on the treatment regimens in the study. In recurrent endometrial cancer, pembrolizumab also has an approval for use in combination with lenvatinib in patients with MMR-proficient disease based on the Keynote 775/Study 309 results. Head back to our endometrial cancer episodes to review the specific inclusion criteria and details of these trials. In cervical cancer, pembrolizumab has 2 separate approvals. It's approved for use in combination with chemoradiation for patients with FIGO 2014 stage 3 to 4A disease. Remember that FIGO 2014 stage 3 disease did not incorporate lymph node positivity, so this is for all patients with extension into the lower vagina, pelvic sidewall, or ureteral obstruction, rectal or bladder involvement. This approval is based on the results of Keynote A18 and does not incorporate PD-L1 status. Additionally, it's approved for use in patients with PD-L1 positive advanced disease, being persistent, recurrent, or metastatic, in combination with chemotherapy with or without bevacizumab based on Keynote 826. Note that, as mentioned above, this is the only PD-L1 expression-specific FDA approval for pembro. Dostarlimab is the other anti-PD-1 agent which has FDA approval for use in GYN cancer. Dostarlimab is approved for use in addition to carbotaxol in advanced or recurrent endometrial cancer based on the results of the RUBY trial. This approval is not dependent on MMR status. In RUBY, dostarlimab was administered for up to 3 years, and the FDA approval echoes this. Other anti-PD-1 agents used in gynecologic cancers include cemiplimab, nivolumab, and balstilimab. Maya, what about anti-PD-L1 agents?
Durvalumab is an anti-PD-L1 agent which is approved for use in advanced endometrial cancer, in addition to carbotaxol for patients with MMR deficient disease. This approval is based on the results of the DuoE study. Other anti-PD-L1 agents used in gynecologic cancers include atezolizumab and avelumab, which at the time of publication of this episode aren't FDA approved. Ipilimumab and falifrelimab are anti-CTLA-4 human monoclonal antibodies, which have been investigated in GYN cancers. Best results have been when used as part of dual checkpoint blockade in combination with anti-PD-1 agents. Nivolumab and ipilimumab were recently evaluated in the CheckMate 358 trial. Okay, so we've gone over the basics of immunotherapy, as well as the details of approved agents in gynecologic cancers. Sydney, what can you teach us about complications related to immunotherapy?
Complications related to immune checkpoint inhibitor therapy are called immune-related adverse events, IRAE. We talked about the biologic rationale for use of immunotherapy in GYN cancers, and the adverse events happen because of that same biologic rationale. Immunotherapy works by unmasking tumors from immune cells, allowing the immune system to attack and kill the tumor. We mentioned that many healthy tissues also express PD-L1, and so targeting of normal tissues is an unwanted side effect of the use of immunotherapy. These adverse events are considered to be off-target effects of the activated immune system, and sometimes can be a sign that the immune system is responding to the drug. In fact, there's evidence that people that experience more adverse effects from immunotherapy also experience better oncologic responses to immunotherapy. IRAEs are common with the use of immune checkpoint inhibitors, with greater than 70% of patients on immunotherapy experiencing adverse events and up to 13% experiencing severe adverse effects in the grade 3 to 4 range. IRAEs are less standard than toxicities from traditional systemic chemotherapy. They can really target any tissue and can present at any time. While it's more common for them to develop in the first few weeks to months of starting treatment, they can occur at any time, even after stopping treatment, even years later. The takeaway for the rest of this discussion will be, if someone has been on or is on an immune checkpoint inhibitor and starts to experience new symptoms, suspect an IRAE until proven otherwise. The most common organ systems affected are skin, GI, endocrine, lung, liver, cardiovascular, and central nervous systems. While IRAEs can occur at any time, median time to onset of toxicities related to CTLA-4 inhibition seems to be shorter than with PD-L1 or PD-1 inhibition. Toxicities related to CTLA-4 inhibition are also dose-related, and higher toxicities with higher doses in trials investigating CTLA-4 targeting agents have led to adoption of lower treatment doses. Maya, how do we identify and how do we manage these toxicities?
I think the most important thing to talk about here is the ASCO guidelines for the management of IRAE in patients treated with immune checkpoint inhibitors, published in 2021. They have really detailed guidelines on the workup, evaluation, grading, and management of an exhaustive list of toxicities that can occur with immune checkpoint inhibitor therapy. Management is based on the grade of toxicity as well as the site. It's way too much information to cover in this episode, but is definitely a paper that we should all have saved and should reference if we suspect an IRAE in our patients. which again should be any time a patient on or previously on an immune checkpoint inhibitor has new symptoms. I think what we can talk about related to toxicities is general principles of management and how these differ from management of traditional chemotoxicities. As we mentioned, management is based on the grade. In general, think steroids, either local or systemic, depending on the toxicity site and the grade of toxicity. So your first step will be to assess the patient, obtain the necessary exam, labs, and testing to rule out other causes, imaging if necessary, and then assign a grade to the IRAE that you're dealing with. Typically for grade 1 adverse events, continuing the checkpoint inhibitor is appropriate and symptomatic or supportive care can be administered. If patients have grade 2 or higher AE, then stopping the immune checkpoint inhibitor is recommended and further treatment is warranted. For most IRAE, standard treatment involves a corticosteroid. The potency and route of location again depends on the grade and location of the AE. For grade 2, while you temporarily stop the immune checkpoint inhibitor while treating the symptoms, you can generally re-challenge with the immune checkpoint inhibitor once the symptoms have resolved to less than or equal to grade 1 severity. Sydney, how does steroid administration and management of cessation of immune checkpoint inhibitors differ for grade 3 or grade 4 adverse events?
For grade 3 and 4 adverse events, it's generally recommended to give high dose steroids and plan for a steroid taper, often tapering for 4 to 6 weeks. If you start your high dose steroids and don't see any improvement within 48 to 72 hours, some adverse events may benefit from the addition of other monoclonal antibodies based on the organ system affected. For grade 3 adverse events, you can consider restarting the immune checkpoint inhibitor once symptoms or labs revert to grade 1 or less severity, but more caution is required than with grade 1 to 2. You may want to consult a specialist, especially if you're dealing with an organ system you're less comfortable with. Restarting therapy with shorter dosing intervals, like every 3 weeks versus every 6 weeks, can also be helpful in case symptoms recur, as the drug will be out of the patient's system sooner. Remember that patients with early onset immune-related adverse events are at higher risk of re-triggering that adverse event after re-challenging with the immune checkpoint inhibitor. If patients were previously on dual checkpoint inhibitor therapy and had a grade 3 to 4 adverse event, consider monotherapy re-challenge with the PD-1 agent. If patients experience a grade 4 event, the immune checkpoint inhibitor should be permanently discontinued, except for endocrinopathies, which we'll discuss soon. Typically, these require urgent medical evaluation, admission to the hospital, and administration of high-dose steroids. One thing that's different than with management of toxicities related to traditional cytotoxic therapy is dose adjustments. For immunotherapy, these are generally not going to be helpful or indicated. If you think you need less of the immune checkpoint inhibitor, you should stop the medication, at least temporarily. Maya, are steroids always the treatment of immune-related adverse events? Are there other options?
No, they're not always indicated. Specifically, with endocrinopathies related to IRAEs, steroids haven't shown to be helpful. This is because the cells producing the hormones are often permanently damaged, so giving steroids isn't going to restore hormone production. Typically, management of these endocrine-related adverse events involves repleting the missing hormone after you determine at which point in the hormonal axis there is damage. For this same reason, continuing treatment with immune checkpoint inhibitors is usually appropriate after the hormone abnormalities are adequately controlled with replacement, because the damage has already occurred, and so giving further immune checkpoint inhibitor won't damage that organ more. Of course, the patient could experience other severe adverse events with re-challenge, and so this always warrants a risk-benefit discussion with your patient. Consult the ASCO guidelines for management of hyperthyroidism. Like in some other thyroiditis conditions, the gland will burn itself out, so it might start hyperthyroid, but typically treatment involves just symptom management until hypothyroidism develops, at which point you then replete the thyroid hormones. For IRE in which you do use steroids, sometimes that's not enough. The ASCO guidelines are also really helpful for this and walk you through options for additional or alternate therapies like IVIG or monoclonal antibodies for severe refractory symptoms. If using steroids for longer than 28 days at high doses, consider using a PPI for stress ulcer prophylaxis, as well as prophylaxis for pneumocystic pneumonia with Bactrim or an alternate if there's a sulfa allergy. So we've talked about re-challenging with immune checkpoint inhibitors. Sydney, when would we normally do that?
Great question. So we mentioned that you want to wait until symptoms and labs are back to grade 1 or less levels. Additionally, it's important to think about where you are in your steroid taper if you're doing one. Because the steroids are blunting the immune system, it doesn't really make sense to restart your immune checkpoint inhibitor, which relies on the immune system, while your patient is on a higher dose of a steroid taper. You'd be counteracting the benefits of both therapies. Before restarting, in addition to thinking about the grade of the adverse event and whether it's even appropriate to consider rechallenge and the patient's oncologic response to therapy so far, asking yourself whether restarting is likely to have oncologic benefit, think about what the current total steroid dose is. You don't have to be completely finished with the steroid taper. There is data from non-small cell lung cancer that restarting when patients are taking less than 10 milligrams of prednisone or the equivalent daily will result in better oncologic response than if total dose is greater than 10 milligrams of prednisone per day. Maya, we've mostly been talking about immune checkpoint inhibitor therapy during this episode. What are other forms of immunotherapy being researched or used in cancer?
Therapeutic vaccines are another form of immunotherapy. There are several in development and approved in other disease sites, but so far there aren't any FDA-approved therapeutic vaccines for gynecologic cancers. Additionally, adoptive T cell therapy, like use of tumor-infiltrating lymphocyte therapy and chimeric antigen receptor or CAR T cell therapy, is in development. This involves transplant of modified T cells which express beneficial receptors. Again, none are approved for use in GYN cancers so far.
That's all we have for you today. We hope you learned something on today's episode of Ready Set GYO, a podcast for Gyn-Onc Fellows. Here are your key takeaways from today's episode. Cancer thrives in an immunologically quiet environment. They've adapted ways to escape the immune system's attempts to identify and destroy cancer cells. Some of the ways they've done this is through upregulation and control of expression of PD-L1 and CTLA4, which are immune checkpoint receptors.
PD-L1 expression is measured via IHC and is reported as a combined positivity score for gynecologic cancers. This score calculates the total PD-L1 expression in tumor and immune cells compared to the total number of viable tumor cells. A score greater than or equal to 1 is considered positive. Microsatellite instability measured via sequencing, mismatch repair measured on IHC, and tumor mutational burden measured on sequencing are other ways to identify tumors which may respond to immune checkpoint inhibition. A tumor mutational burden greater than or equal to 10 is considered high.
Pembrolizumab, an anti-PD-1 agent, has tumor-agnostic approval for use in advanced TMB high, MSI high, and MMR deficient solid tumors based on the results of Keynote 158. Additionally, pembrolizumab has disease-specific approvals for use in advanced endometrial cancer regardless of MMR status, based on Keynote 868, and for use in recurrent MMR-proficient endometrial cancer in combination with lenvatinib, based on Keynote 775. Pembrolizumab is approved in cervical cancer for stage 3 to 4A disease in combination with chemo, regardless of biomarker status, based on Keynote 818. And for PD-L1 positive advanced disease in combination with chemotherapy based on Keynote 826. Dostarlimab, an anti-PD-1 agent, is also approved for use in advanced endometrial cancer regardless of MMR status based on the RUBY trial. Durvalumab, an anti-PD-L1 agent, is approved for use in advanced MMR-deficient endometrial cancer in combination with chemotherapy based on the DUO-E trial.
Other anti-PD-L1 and anti-PD-1 agents, including nivolumab, atezolizumab, avelumab, and cemiplimab, are used in gynecologic cancers. Anti-CTLA4 agents like ipilimumab and fadraciclib are often used in combination with PD-1 pathway agents as part of dual checkpoint inhibition.
Immune-related adverse events, IRAEs, are common, and most patients on immune checkpoint inhibition therapy will experience some. They can occur in any organ system in the body and can show up at any time, even after patients have stopped taking the immune checkpoint inhibitor, so it's important to have a high suspicion. Management is based on grade and organ site of toxicity, and guidelines from ASCO published in 2021 offer a comprehensive resource for management. While most management involves steroid therapy and at least temporary cessation of the immune checkpoint inhibitor, endocrine-related adverse events are managed differently.
This has been another episode of Ready, Set, GYO, your source for all things gyno.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Oesch and Maya Gross. Our sound editors are Brogan Brown and Kylie Knight. Our media and website manager is Sky Jacobson.
We'd like to thank Dr. Jen McDonald, faculty at the Medical University of South Carolina, who reviewed the content of this episode for accuracy and completeness.
Sydney and Maya signing off.